Good evening, everyone, and welcome to what will, I'm sure, be a very lively discussion about healthcare reform, right? Very exciting topic. My name is Pete Damiano, and I have the pleasure of being the director of the University of Iowa Public Policy Center. And these Wonk Wednesday events are a part of our community engagement mission at the center to try to share the expertise, other than when I'm talking, of the Public Policy Center and the people who work with public and policymakers on some of the more relevant issues of the day. Healthcare reform back in the news this afternoon when it looked like it was all but over. So really like to engage you in some discussion as well as, lecturing at you tonight. So tonight we're going to really be talking about what is the Affordable Care Act. Heard about it a lot, Obamacare. What is it? There's a lot of confusion about that. What was it really trying to accomplish? What do we know about what it was able to accomplish up to this point? And then all this discussion about repeal, replace, repair. What do those things mean? Is it dead? Is it not? Obviously, I don't claim to have a crystal ball, but there are some things that are being discussed that I think are relevant to keep an eye on for those of you who really do care about these issues. And really want to start by giving a shout out to the Health Policy Research team at the Public Policy Center. We've got a great we do everything from working, do a lot of work on Medicaid reform, the Medicaid expansion, healthy behaviors associated with that, physical and mental health chronic condition programs, school nutrition, lunch, family planning, state innovation, oral health services research. And when we do this, we're doing this not from an advocacy perspective, but we're here to do the academic research, come up with the best answers that we can, and share that information with policymakers and the public in a way that then hopefully will allow policymakers to make better decisions. So tonight, not here to say whether the Affordable Care Act is good or bad. And I think if you think about any big piece of legislation, whether it's Wall Street reform or a large transportation bill or the ACA, there are things that are going to be more effective and less effective at that. And one of the things that's really important, I believe, when you're trying to evaluate policy is breaking it down into smaller pieces and parts. You'll hear all the time, Obamacare is broken, ACA is great, whatever it is. It was really the next in an iterative stage access to care in the United States, as well as trying to improve quality and efficiency of care through a variety of different approaches that are within the bill. You hear all the time about its 2,700 pages and how could anybody understand it and all those kinds of things. But the reality is it's got millions of pages of implementation. And so the bill itself, if any of you have tried to read it, you really can't even read it or understand it by looking at the language. So much of it refers to the Social Security Act of 1933 and changing this line and this sentence and all of those kinds of things. But then it's then the interpretation of that and the implementation at the state and the federal level and sometimes the local level that really affects whether something works or not. And so that's one of the things I'd really like to sort of challenge you, if you will, to when you're thinking about the Affordable Care Act and what it's doing, trying to break it down those pieces and parts. Sometimes that's something, well, how does it affect me? Sometimes it's how does it affect other constituencies that you might really care about. And that's what we try to do through all of these things. We publish this, all the research on our website, so if any of you are interested in reading these things, that's all published and available. And I'd like to really encourage you to do that and give a shout out to my colleagues here who have been involved in that. Many of you have seen this quote, which at first blush sort of strikes you as kind of really, but healthcare reform can seem very complicated. But it wasn't the first time that a president was accused of having complication in terms of healthcare reform. This was early on when the ACA was being discussed. That's President Obama over there saying, maybe I should have been more specific. And again, you go back to that whole idea of this is 1/6 of the economy. This is a huge number of moving parts and pieces. We normally think of this as really being about health insurance, and that's the part of the discussion that's going on. But there's many, many more components of that that affect it, especially the delivery system, changes. And I'm not going to get into that too much tonight, but those are the things that I think are really changing healthcare right now and the healthcare delivery system and the healthcare system overall in a way that's very profound and often misunderstood in terms of the attitudes of the public towards the ACA over time, and they have been shifting. But obviously, as we talked about at the very beginning, when you talk about really complex pieces of legislation, it's very difficult to understand all the pieces and parts, and people tend to look at the talking heads that they're most comfortable with and take that information. But just for yourself, how many of you, if we said on a scale of 1 to 5, 1 being I've heard of the Affordable Care Act, 5 being I could give this talk, how many of you would say you're a 1? Okay. How many a 2? How many a 3? How many a 4? How many a 5? Shoot, nobody wants to, okay. So, even in any room like that, you get a mix of people in terms of how comfortable they are with things, obviously. And so, when I think about the ACA and the way I'm going to talk about it tonight is really breaking it into these 2 components. The first is the insurance expansion part, and that's, again, where we've really put a lot of the emphasis on this, and that includes the individual insurance market, which is the part when you hear people saying Obamacare is broken, that's what they're talking about, the small business insurance market, and then you've got the public side. And then on the delivery system change, as I mentioned earlier, this is the part that's really changing things drastically, but it's much more under the surface. The development of accountable care organizations, the development of network organizations that are working together in a way that they were never allowed to before, and that's really changing the delivery system for healthcare providers in particular and what's going on there, and it's rolling over and is going to be affecting consumers as well. But before we even get into this, one of the things that gets lost often when we get into a discussion about healthcare is what it's all about. So when you start talking about different aspects of the ACA or insurance, so often it gets down to the market aspects, if you will, or the fact that healthcare and the healthcare providers, that what's lost in all of that is the fact that the only reason we have any of it is to make ourselves healthier, right? But if you think about what are the things that actually make us healthy, and you could argue with the percentages here, a little bit this way or that way, but roughly half of our health status is related to lifestyle issues, right? What are some of those kinds of things? Smoking.
Not wearing a seatbelt.
Not wearing a seatbelt. I'm sorry?
The food we eat, vegetarian, pescatarian, veganism.
Sure. Nutrition, right?
Lack of
exercise, all those things that really affect whether we're healthy on a day-to-day basis, also the things that we know we should be doing, and we all sometimes do it and sometimes don't, and all those things. About 20% are environmental factors, roughly 20% is our genetics, right? We all know people that have smoked and died when they're 20, other people that have smoked and lived till they're 90, and then the healthcare delivery system really only affects about 10% of our health. But where do we put our resources in the United States? Right? Yep. So we put about 90% of all of our resources into what affects about 10% of our health. Now, does that mean that that's a bad thing? No, that's just what we do. But we often talk as if we have a healthcare system in the United States. And President Bush's Secretary of Health and Human Services, I think, described it best. We have a series of healthcare sectors, but we don't have a healthcare system. And they don't necessarily work together very well. And it's not like we've decided. How much do we spend on healthcare in the United States in a year? Anybody know?
A lot.
A lot? That's the correct answer. About $3 trillion a year. And, did we decide that at the beginning of the year because that's what we needed to spend to be healthier? No, it's just sort of what happens, right? And that's not, we're not looking at it. If you took a systematic approach, you'd be looking at where do we have need, where would we have our resources, and how would we apply those needs of those resources. Not even suggesting that we should do that, but when you think about the policy levers and how to influence things, this makes it more challenging to be able to do that.
How much do other countries spend on medical?
Much less, both on a per-person basis and as a percentage of GDP than we do. What you'll often hear is they spend much less and they have better outcomes than we do. It's actually a lot more complicated than that. That's a very simplistic approach. However, there is reason to question that we could be getting more for all of what we're spending. So when you talk about then, so what does determine whether we're healthy or not, which doesn't often get into this discussion in the way that I think it should. And if you've looked at been following some of the recent discussions about where some cuts have been wanted to be made to be able to pay for some of the tax cuts, one of the places is in the public health fund that was set up with the ACA. Well, you look at what are the things that determine whether we're healthy. Early childhood development, 0 to 5, we know is huge. Education, employment, food security, all of these things, of which healthcare services is one of those. And this is a place when you look at the proportion of spending in other countries on those things versus the United States, it's very different. But if we were going to be looking at it as how do we make our population healthier? Housing, for example. Some of you may have come to the poverty policy session that we did here last week. And that was primarily on the discussion revolved around housing. Because if you don't have adequate housing, how do you get a good job? How do you have, all of these other things follow from that. And housing, especially in Iowa City, is extremely expensive. And if you have to work for a living, it's really tough to live here. If you're a non-student, it's very, very difficult. And then these other things sort of follow from that. So just don't want to get that lost in all of this. And what's also happened over time, if you look at that issue about behavior, it used to be in the 1900s, these were the reasons that most people died. You look here, this is the reason, but this is actually the cause behind that. And what does that say about those different issues? What do you see there? What's the change over time?
Environmental factors like fire.
Right, well, environmental and behavioral things, right? Tobacco, diet, activity, alcohol use. A lot of those things, again, are behavior that then drive these issues on which actually people die from. So it gets back again to that behavioral issue. Very, very difficult to change people's behavior, right? We don't know how to do that very well. So get directly to the ACA now. When we're talking about the insurance expansion, in the United States, we've taken a very incremental approach to this versus other countries. But if you think about what the approach to the ACA was, it's often sort of talked about as this left-wing government takeover of the healthcare delivery system. But from an insurance perspective, it's actually somewhat of a right-of-center approach with the individual mandate. Nobody likes that, and nobody likes to be told what to do, but this was originally a proposal, came out actually in President Nixon, when Senator from Kansas, who was running for president, blanking it. Bob Dole was running for president. He proposed that because the idea was that the individuals should be responsible themselves and be able to help carry. That if you have somebody who's uninsured, we all pick up the costs for that. And the way that's different with the Obama approach than it was during the Clinton approach, the Clinton era, it was an employer mandate, which said that the employers down to, I believe it was 7 employees, were going to have to provide health insurance for their employees. In this approach, it's up to the individual to be able to do that. And what they did is they set up the individual health insurance exchanges or marketplaces as a way to keep private insurance in the game by subsidizing the purchase of private insurance for individuals. Again, a conservative approach to keep private insurance in instead of doing it as a government takeover of everything. But what we have done in the United States is we've shifted the highest cost, highest risk people into the government programs in Medicare and Medicaid, and we've left the lower risk, younger, healthier people in the employer-based side, which again, it's not good or bad, but we've done that, and then we sometimes wonder why are those programs so expensive? Well, that's where the sickest people are. Medicare, the program for seniors, Medicaid, low income, but primarily most of the money goes into people in nursing homes and people with disabilities. And so we've carved those people out. So having robust public programs actually help the private insurance side as well. So this is that incremental approach that we've taken in the United States. The first insurance we had was really being offered during World War II, when there was a wage and price freeze on due to the war. And so employers, to be able to attract and retain employees, started offering health insurance. Then that was popular. Then right after the war, the government said, okay, we're going to encourage that by allowing businesses to write that cost of that insurance off of their taxes. And that's to the tune of about $150 billion a year. And so most private insurance is already subsidized prior to the ACA through that, particularly for larger employers. Then we had Medicare and Medicaid picking up the next big gaps of people. Then in 1997, we had the Children's Health Insurance Program, which is for children of the working poor, basically up to 300% of poverty. And then with the ACA, the last groups, if you will, to pick up were primarily single adults who were not eligible for Medicaid before. About 80% of them are working people and their families. So this idea that, work requirements and Medicaid and all those things sound like good, if you will, but for the most part, most of those people are already working in low-wage jobs, don't get health insurance as a benefit, and it's extremely expensive to buy that. About 2/3 of them making $50,000 a year or less. And so anybody know what the average family health insurance policy costs in the United States right now? Very good. $18,300 is what they say is the average cost of a family policy. If you're making $50,000 a year or less, there's no way that you have that kind of disposable income to purchase that out of pocket. So the ACA was set up to take some of those folks and put them into the Medicaid expansion for the lower income group up to 100% of poverty, and from 100 to 400% for them to be able to buy private insurance on a sliding scale through the health insurance marketplace. And so up to 2014, and this is when a lot of people think the ACA started, because that's when the individual mandates started and the marketplaces started. But there were already a number of things in place, some of those that were talked about in the video. And we did a study at the center looking at those exact issues among people who were uninsured and were likely, because that was before 2014, to be purchasing insurance through the exchanges. And we've got the same thing, about, is this popular? Absolutely. Getting rid of annual maximums, lifetime maximums, pre-existing conditions, all those things. Yes, yes, yes. Do you like Obamacare? No. And it's a really, again, that's why I encourage you to tease apart these policy things to try to understand those distinctions, because it's really tough. This is one that's kind of interesting because government programs are often criticized for not being efficient. Well, Medicare and Medicaid run at about a 6 to 8% administrative overhead costs. This is trying to force the insurance companies, the private companies, to get to 15 to 20%. And if they don't, they have to pay a penalty, and there literally have been billions of dollars in penalties and rebates that have gone back to consumers because the private companies couldn't get to this. Again, doesn't mean good, bad necessarily one way or the other, but it is kind of administrative waste in there. You're going to hear a lot of talk probably coming up to the next election about some sort of a single payer. And the argument that's going to be made for single payer is this, that we're going to save a whole lot of money if we went to a single government program. It's obviously a lot more complicated than that. Trying to convince people who have good private insurance that they should give that up for something that's uncertain is a real political risk and things like that. But that's part of the argument that you're going to hear being made. Then on beginning of 2014, when the individual mandate came in, and from an insurance perspective, that's when the Medicaid expansion began and the health insurance marketplaces. So this is what it sort of feels like to people was the beginning. So in terms of the mix of health insurance in the United States that we have, about half is employer-based insurance, about 14% is Medicare, 19% Medicaid, and this is a switch that just happened within the last 10 years in terms of there used to be the higher proportion of people in Medicare, and that's switched to a higher proportion in Medicaid. 7% in non-group insurance, so that's the individual small business market. And this is when you hear again about a lot of the challenges with Obamacare right now or with the insurance, it's in this part. It's not in any of these big pieces, it's in this part right here. That doesn't mean it's not important for those people who are in that 7%. It is really important, but it's not as large a proportion as you might think from what you hear. And there's still about 9% of people in the United States who are uninsured for various reasons, even with the individual mandate. So in terms of the government supported insurance, as we were talking about, and again, we often think of ourselves as having sort of a private system, but we've got Medicaid, the expansion in about half of the states. We'll talk about Medicare for seniors, the Children's Health Insurance Program, the tax subsidies for employer-sponsored insurance, the subsidies for people in the marketplace, and then all of the government programs like the VA, military community health centers. You add all of this up, and that's about 50 to 60% of all of the healthcare spending in the United States is actually through government programs already. Medicaid in particular, because this is a key part of the ACA, I think it's important to understand this a little more. It's about 74 million people, and this is a revolving number. And so this is something that people come on and off. My colleague here, Betsy Momini, has done some good work on churning in the Iowa program. And after about 2 years, about half of the people who were in the program at the beginning are already off the program. And so that's not necessarily, it's generally a good thing, but that assumes on where they're going from there makes good sense. But it's a large proportion of the population, 1 in 7 adults, 2 in 5 kids, 1 in 5 Medicare beneficiaries are also dual eligibles in Medicaid. 3 in 5 nursing home residents are in Medicaid. This was something that was not considered when Medicaid was first started at the beginning. There was not consideration that there was going to be paying for nursing home care, but when you started getting seniors who were low income, that's what they needed. And so now that's a huge portion of the budget. Spending growth is due primarily to increased enrollment, not necessarily higher costs. And the high cost, high utilizers in Medicaid, as I talked about earlier, really buffer that private insurance market. Then the health insurance marketplace is the other big part. So you have the Medicaid expansion and then the health insurance marketplace. That's the healthcare.gov. That's for subsidized insurance up to 400% of poverty. There's an interesting, I guess you would call it interesting, unintended consequence might be a better way to put it in this, in that people from 0 to 100%, particularly in states that didn't do the Medicaid expansion, have no option to get subsidized insurance because the way the law was written, there was an assumption that everybody at 0 to 100% in all states were going to be in the Medicaid expansion. When the Supreme Court took up the case to look at the constitutionality of the individual mandate, and you might remember Justice Scalia's famous comment about, well, we shouldn't be forcing people to eat broccoli anymore, that we should be forcing them to buy insurance. Well, one of the 4 things that they picked up was whether the states could be required, that had a Medicaid program, could be required to be a part of the expansion. At the time, no one thought that that should have even been picked up, and no one thought that that would be overturned. The big question they all thought was going to be on the individual mandate. Turns out that was the only piece that the courts ruled was unconstitutional. So now you've got this weird result that people from 0 to 100% can't get the subsidy and can't, like if you're in Texas or Florida, some of the biggest states with the most uninsured, and you can't do anything and you don't have any other ability, you can't get subsidized insurance. This is one of the things that there's a lot of challenge about or a lot of discussion about in terms of should the ACA have done this? And that's required an essential health benefits package. In the past, for what were considered non-compliant plans and plans that were grandmothered or grandfathered into the ACA, they don't have to cover all of these things. And so this is one of the issues that some people are complaining about. Well, we shouldn't have to cover all these things. You know, why should men have to pay for maternity care? Okay, why should women have to pay for prostate surgery? You know, you know, where do you draw this? The big one of the big ones is mental health. And so we've worked for a long time in the United States to try to get to some what's called mental health parity, to try to get mental health to be considered equally important as physical health. And when you think about the high cost, high utilizers in the system, many of those people are a combination mental health, physical health, have chronic health conditions in both. Those are the folks who often end up in the emergency room, often get re-hospitalized, a lot of other issues like that. And so, you know, for the first time we were starting to move in that direction, there are people who say, well, you know, I don't need mental health coverage, why should I have to pay for it? Well, you know, if you really think about this from a population perspective, Where do you draw that line? You know, which of these things would you say shouldn't be covered? It's a really tough call. And this is when you start hearing about catastrophic insurance. Right now, only people under 30 can buy a catastrophic insurance policy with the belief that many of them are going to be healthier, aren't going to need some of these things. And at least they will be covered in the event of, you know, riding their motorcycle without a helmet or cancer or something like that. Whereas we get older, we know we're going to be needing a lot of these other things. So the delivery system change, again, just want to touch on, and this is the thing that I think is really happening both quickly, and if you think about our knowledge and our ability to do them between the insurance coverage and the delivery system change. Do we know how to provide health insurance coverage? Sure. Could we, if we wanted to, could we provide health insurance coverage to everybody tomorrow? We could. Whether it's the right thing to do, whether it's what we want to do, that's a different issue. But we'd have a mechanism. We could put everybody into Medicare and put everybody in Medicaid or something like that if we wanted to. Do we know how to deal with those high cost, high utilizers, the 10% of the population that uses 69% of all of our healthcare costs? Those people who are the dual diagnosis, mental health, physical health people. No, we don't. And so an attempt to try to deal with that was the development of what are called accountable care organizations. This is, again, what I would consider a conservative approach to try to bring market forces, if you will, into it. And it was originally just a small piece of the ACA that was a part of the Medicare program only. Iowa had one of the first 13 what were called pioneer ACOs. And the idea was to allow delivery systems, hospital systems, and others to work together in a way that they weren't allowed to before by law, because it would have been considered collusion, in a way to try to hold down costs and improve quality at the same time, and manage those people with those multiple chronic health conditions. It then spread from there to the private health insurance companies, and that's the way actually a lot of the health policy has worked over the last 40 years, has gone from Medicare over to the private side, and trying to address what's considered population health. So the idea is that a health system like Unity Point or the University Alliance is now supposed to be taking responsibility for their covered lives. They have a population of people that are attributed to them, and they're supposed to be managing them. And if they do a good job of holding down the costs and meeting a certain quality threshold, they would originally get some sort of a reward. Now it's actually flipping where there are some arrangements like this that if they don't do it, they're actually going to get penalized. And this summer, calling this value-based purchasing and other types of things, but it's something that basically every health system in the country is struggling with and trying to figure out how to do that most effectively. And it's very difficult. Care coordination and case management are the way that everyone thinks is sort of the panacea to doing that. Medicaid managed care is expanding as well, and that's another component of this. Many of you are probably aware of what's been going on in Iowa. There has been managed care in Iowa going back to 1991 in various forms. The thing that's different about what's happening now is that it was everybody in overnight with not a lot of preparation in advance. And by everybody, I mean people in nursing homes, people with disabilities who had not been in managed care situations before. And that's a very, very difficult thing. They're very difficult populations to manage. And then you also have to take out the administrative fees and the profit for those companies from the Medicaid program, which was already very lean before. So that's why you're hearing a lot of talk about those struggling. So this is really rapidly going on across the country, and everybody's trying to figure out how to do that. So what do we know about what the ACA has done? So we still have, as I mentioned, about 28 million people who are uninsured, much lower for children than adults. Iowa has always been one of the lower uninsured states in the country, which might be a little surprising with people who are farm families and others who have to go out. But as many of you know, many people who farm have either a spouse or whoever farms works off farm to get benefits. You have Farm Bureau that's been connected to Wellmark for years, and you can get individual insurance through there. And so our child uninsured rate from some of our research is about 2 to 3%. The adults is about 9%. You went from 50 million uninsured, though, to 28 million uninsured with the ACA. So about 22 million people picked up insurance coverage through the Affordable Care Act, through the Medicaid expansion, and through the private insurance through that marketplace. We still have in the neighborhood of 25 to 35 million people, though, who are underinsured. So those are people, many of them who think they've got really good insurance until they run into the situation that they need it. And then all of a sudden they have some sort of a catastrophic problem. They go in and they realize that insurance doesn't cover it all. And that's where the United States is very unique from other countries where we have many bankruptcies that are due to healthcare costs, which is unheard of virtually in any other part of the world. So with the Medicaid expansion, this is sort of the map on the states that chose to do it or not. Ironically, to some extent, it's a red state, blue state. Might make sense, it might first blush why that is, but the Medicaid expansion, that population was being paid for 100% by the federal government for the first 3 years, and it's still 96% right now. And so these states are leaving literally, collectively, billions of dollars on the table to not cover the residents of their state with insurance, which they could basically for free. And all the states give money in, and many of them look at how much they give in before versus how much they get back from the federal government. And there's states that argue about whether we're a giver or a taker, and things like that. Well, this is one where they had the choice and opted not to, really pretty much for political reasons. But the end result is a lot of the largest numbers of uninsured are still in these states here. And there's numbers of studies that have demonstrated the value of the Medicaid expansion to people in those states and to those states and the health status and other things. So in terms of employer-based insurance, there's been a slight increase overall as a result of the ACA, mainly because of the mandate for 50 companies with over 50 employees. But what's sort of interesting is when we're talking about that individual insurance market and Obamacare being broken, and basically what that means is that those people who don't get it through their employer want to buy individual insurance, or a small business that has 5 or 6 or 10 employees and go out to buy it, that those markets are gotten really tough because the risk pool isn't what it needs to be robust enough that the insurance companies feel like they can either be a part of it or that the premiums haven't been going up so much to cover those costs. And one of the reasons for that is that not nearly as many companies actually dropped their insurance as was projected by the Congressional Budget Office at the beginning. There was an expectation that when the marketplaces were started, and there was something called the shops, which were the small business insurance programs, which really haven't taken off very well, that a number of businesses would say, here, I'm going to give you some money and you go out and buy it off of here, because it would be kind of a win-win for both. That didn't happen as much. And it makes sense, really, when you think about why do most employers offer health insurance to their employees? Why did they before when they didn't have to, and why do they still, even the ones that don't have to? Incentive for what? Right, it's recruitment and retention, right? It's often thought about, well, it keeps your employers healthier. Not, again, if you think about what makes us healthy, a small part, but it's a recruitment and retention issue. So that's what they were doing before, and that's what they're doing now. So they're not dropping it because that's sending the wrong signal to many of their employees that we don't care as much if we're going to push you onto this other program. And so, but what that did is it didn't help that mix of people in the individual market in the way that they thought, where there would be younger, healthier people going in. And so that's been a problem. The quality of employer-based plans, though, has improved. Because of that essential health benefits, it also has increased the cost. No lifetime caps or pre-existing conditions. And actually you hear about all this talk about the premiums going up, and they are. But if you look at what they were going up before, there's sort of this misunderstood that the individual and small business market was fine before the ACA, and then the ACA came in and screwed it up. Well, it was actually broken before, because that's when you had pre-existing conditions, and that's when you had annual maximums, and you had lifetime maximums, and you had premiums going up a lot before. And they actually haven't been going up as much since. Are they going up? Absolutely. This year, you're going to see them going up even more because of the increased uncertainty, because of the federal different rules like getting rid of the cost-sharing reductions and less marketing and potentially less people joining through the health insurance marketplaces, although the early numbers are actually higher than what they were last year. You know, we'll see what it is, but they've also shortened the enrollment period to only a month and a half and moved it up. So there's a number of things that are going to make it really difficult to have a robust individual insurance market to be able to get the risk pool in the way that we would want it to do. The grandfathering and grandmothering is also a problem. In Iowa, we only have about 72,000 people who purchase it through the health insurance marketplaces, but we've got another 72,000 that have been grandmothered and grandfathered into non-compliant plans from before. And if all of those people were in the individual market, again, that risk pool would be better. In addition, Iowa's had the lowest proportion of marketplace eligible people purchase insurance. The last data I saw, only about 20% of the people who were eligible for a marketplace insurance program picked it up in Iowa. And so that means you've got a lot of other people that had they joined, that risk pool would be better. But we've done nothing in Iowa to market it. You know, that we don't even, there's some healthcare navigators. Funding for that got cut this year. Those are the people supposed to help. Even before, we had 20 counties where there were no navigators. And so, you know, you don't see billboards, you don't see TV advertising, any of those kinds of things that would have drawn more people in, which would have helped increase the risk pool. So a lot of problems there that could be, if we really wanted to address this from a policy perspective, there's things we could do to shore that up. So the uninsured rate, with private insurance, among the uninsured going down, and those with public insurance going up overall between 1997 and 2016. So this is the first couple of years of the implementation of the ACA. Uninsured children by poverty status, the poor, near poor, both declined significantly in terms of the proportion of uninsured kids. Uninsured adults by poverty status, again, significant decline, and still some decline among the non-poor, but among poorer adults, significant decline. By race ethnicity, among Hispanic, non-Hispanic blacks, non-Hispanic whites, a decline in basically every race ethnicity group. And one thing that's not talked about a lot is, because the ACA, the language that you hear is often, well, it's for those people. You know, it's not for me. Well, one of the things that it is for all of us is uncompensated care. So that was that whole idea of why you had the individual mandate and why everybody was supposed to be in this together to help everybody else. And that's uncompensated care. So those people were uninsured before. Interestingly, if they went into the hospital, paid the highest rates because there has to be some sort of a charge. Otherwise, it's fraud when you go in. But then every other insurance company and every other plan negotiates for volume down from that. But somebody still had to pay the charge, and that's the uninsured. But so when they went in, their costs that aren't being paid for get shifted to all of us. Well, the amount of uncompensated care declined significantly, and you can see in the Medicaid expansion states much faster and to a much greater level than those in the non-Medicaid expansion states. And so if you've been hearing just in the last day or two when there's talk again of getting rid of the individual mandate with the tax plan, who are the ones that are screaming? Hospital associations, the physician groups, those folks who know that if that goes away and another 13 million people lose their health insurance again, those costs are going to come back and they're going to get shifted to everybody else and they're going to lose that money. Where does the individual mandate come from anyways? Why was it in there? Right. So again, it's sort of often thought of that as this is a government big brother, everybody should have insurance thing. But it was actually a private sector thing. The only way the private insurance companies said, we'll get rid of pre-existing conditions, annual maximums, be a part of the marketplace, is if you say everybody's got to go in. If you don't, then people cherry pick. They only buy the insurance when they need it. And so if you get rid of the individual mandate, even though it doesn't affect that large proportion of the population, but it feels to all of us, you know, we don't like being told what to do, but it will affect everyone, and it will affect premiums. As the report just came out, premiums will go up, and the number of uninsured will go up. So in terms of the repeal and replace, as you know, the Republicans have been campaigning for 7 years on this, but as I mentioned earlier, the policy and political landscape has changed over time. And I don't mean this from a partisan perspective. This is just, obviously you all know, this is what's been going on. And this was what Senator Grassley said a few weeks ago. You may have heard this comment. And what's troubling to me about this as a policy person is that it makes it very difficult to have a discussion about the pieces and parts or the implications of the bill when people aren't voting on that. You know, they're voting on the fact that I said I'm going to do it for 7 years, so by God, I'm going to do it, even if I know that there's going to be negative ramifications for the state or people like that. And I think it's a very tough place to be, to have that discussion about what are the implications of something from a policy perspective. So as we talked about earlier, people originally liked those pieces and parts, but they didn't like the whole. More recently, though, the attitudes towards the ACA have actually flipped. And so where it used to be a majority against, now it's actually a majority for, in support of, just not necessarily at the level that I might like their knowledge to be now any more than before, but at least at that first blush of, you know, Obamacare good, bad kind of thing, now over half say it's good, which means this environment and the discussion about repeal and replace or repair is in a different place you might think that it would have been before. So as I mentioned, when we talk about Obamacare is broken, we're really talking about that individual or non-group insurance market, but it was broken before as well. We talk about a little more specifically about some of the most recent attempts at repeal and replace. The most recent one was Graham Cassidy, and that was going to eliminate the individual mandate, eliminate the employer mandate, and reduce the expansion population match first to 90%, and then eventually eliminate that, to go down to what the regular Medicaid match is, which is about a 2/3, 1/3 match. So in Medicaid, the state pays about 1/3, the federal government pays about 2/3 for all the costs. Now, that 1/3 is still very significant to state governments. And so even if you're supportive of Medicaid or Medicaid expansion, the reality is it's competing at the state level with education, K-12, higher ed, and a lot of other things because it's so expensive. So we do have to think about what are the options and what we can do, but it doesn't, taking away the match for the states is going to push more costs and more responsibility on the states that they're going to have to pick up. It's not like it's going to go away.
Talk about
Yeah.
the poison pill, that there were state policies connected to that federal policy. So if that actually went down, some states had it in their policy for expansion, that the minute that percent match went down, it was a poison pill that stopped the expansion completely.
Right. So
they linked it to the federal policy.
Right. So, yeah, there were a number of states that were, let's just say, concerned that even though it was a 100% match at the beginning, that it wouldn't stay that way. And so because of that, they had written in, if it drops to a certain point, then we're going to bail on the expansion. And that's part of the reason why if these things happen, the number of uninsured by all the CBO reports estimates are going to be going up significantly. So then in 2020, the Medicaid per enrollee was going to be shifting to a block grant. And so the idea, again, doesn't sound too bad, except the block grant was designed to cut costs. So that means less money that's going to go to the states. So it's a cost shift from the federal government to the state government. So the state was either going to have to increase their taxes, or they're going to have to cut services, or they're going to have to cut eligibility. And there's going to be this, under any of these repeal and replace plans, the pressure on the states was going to be significant. So that was the ACA eligible adults. The repeal of marketplace tax credits, so that was when you'd go in and buy that subsidized private insurance. That was going to go away. They were going to give states flexibility to adjust that essential health benefits list and say the plans didn't have to cover all of those. And the premiums right now, one of the things that was changed to try to stabilize the market was that the way that they could adjust rates for that insurance policy was limited Now they were going to, again, change it so that you could do it based on gender or other kinds of things as it was done in the past. So traditionally, women that would buy an individual insurance policy through the individual market would pay higher costs than men because of pregnancy and some other things like that. The CBO report card, this was the one that Graham Cassidy in particular, you might recall, they were trying to get this through within a week. At the end of September, because if they didn't do it by the end of September, then the vote was going to have to instead be if a 51 vote was going to jump up to 60, and we don't get into all of that. But they did it so quickly that the CBO couldn't really even come up with a good score on it. They did say they thought it was going to reduce the deficit by about $133 billion. This is the kind of discussion that you're hearing right now with the tax plan, that because the tax plan's cost the increase to the deficit, they can't go over $1.5 trillion. And so one of the ways they're trying to bring that back is by getting rid of the individual mandate, which is actually estimated to save about $336 billion, I think it is, but would increase the number of uninsured by 13 million. And so, you're really trading off what your priorities are. And a lot of this has to do with reduction from the block grants. So that's where it's going to squeeze the states. They couldn't come up with an exact number, so they just said millions more were going to be uninsured. But if you look at some of the previous ones earlier in the year, even though ultimately this $337 billion reduction over time, it would increase the number of uninsured by 24 million, were the CBO estimates on some of those previous reports, up 14 million right away. And then individual premium increases, this was 15 to 20%. What they're saying now with the tax plan would be on average at least 10% a year. Then there's what's been considered the repair. And this is, to me, the way we would want to look at policy in whatever area. Let's see what's there. Let's see what's working. Let's see where we want to fix something. Are there problems still? Absolutely. And are there problems in the individual and small business market? Absolutely. Are premiums going up higher than most people would want? Do we still have, not enough people in that in the way we would want? Absolutely. So let's figure out how we would want to do that. And that's what Senator Alexander from Tennessee and Senator Murray from Washington, this was a bipartisan effort to try to come up with a repair for this, to try to stabilize the individual insurance market. So a lot of the things that are being done right now are really political ways of undermining and to try to make the ACA look bad in essence, but not necessarily improve, like in this case, if you're really trying to stabilize the individual market, the last thing you'd want to do is get rid of the individual mandate, because that's how you get a better risk pool in there. Last thing you would want to do is get rid of the cost sharing reductions. So what that is that for people from 100 to 250% of poverty, when they were getting a subsidized plan through the marketplace, they also got help with paying for the co-payments and the out-of-pocket costs because they couldn't often afford those. Those were payments that went directly to the insurance companies, and that allowed the insurance companies to lower their premiums. Well, one of the other reasons that you're seeing the insurance companies, and in Iowa in particular, those of you who have been following them, Medicaid is the only private plan left, on average increasing rates here 58%. They had factored in the loss of the cost-sharing reductions, which meant that the premiums were going up an extra 10 to 20%. And so that's what's happening right now. So they were going to stabilize that, allow more people to buy catastrophic insurance. And again, this is the kind of thing that you can have a reasonable policy discussion about. How comprehensive should the insurance be that somebody buys, especially when you talk about higher cost. A lot of it's in that catastrophic part, giving more state flexibility. And this is where our evaluation work and our research really runs into this, because there has been a lot of flexibility to the states and Medicaid for 40 years. And we do a lot of the work that when they get a waiver, we look to see whether it's working or not. Well, they want to make it simpler for that to happen and quicker. Well, by doing that, you lose the accountability aspect. And so you've got to be really careful in saying, well, we're going to make it easier, but then we're not holding the states accountable to see if something works or not. There's all these things about healthy behaviors incentives in there that our research has shown don't work, and in fact cost money, Cost a lot of money to administer, but it makes us feel better because we're making somebody, get a well person exam or something like that. But the cost of doing it and the amount of people that lose coverage and all these other things, it doesn't work out. So that research, we believe, is really important. So is health reform dead? No. So you've got that issue of that end of September. That was because what was considered, what was called reconciliation, the bill, that ran out, but that could be put in again at any time when they get a budget during this upcoming year, which would then allow them to get back to a 51 vote margin to be able to change some of the AC or repeal it. So that's still on the books. You've got Senator Menendez right now in New Jersey, you might have seen, who's been in trial and just had a hung jury. So if he were to lose, you've got a Republican governor names a Republican senator in New Jersey, all of a sudden the numbers change. You could now flip this if that happened. You've got the Roy Moore stuff going on in Alabama. You've got, if for some reason that would flip to a D. We're so close on the edges, but there are different Senate rules and ways that they can make that work. But the biggest issue is really with administrative rules. And there's a lot of things that can be done with administrative rules to either undermine or change, like we're talking about, a lot of the foundation for the pieces and parts that are needed to work. One of those could be more flexibility to the states. It's not all bad if they can do some of that if you do it appropriately. But how you do that, you still have the accountability. Repeal the individual mandate was just added to the Senate tax bill just yesterday. And, if this were to happen, then it would free up that $300 billion plus that they need to be able to get to only $1.5 trillion in increase in the deficit. But 13 million people would lose their health insurance over 10 years. And so it depends on, your priorities and where you'd want to trade those things off. So health reform is not dead. There's something that is still going to be important to pay attention to. Those of you who buy individual insurance or buy small business insurance, it's going to be really important to kind of keep an eye on what's going on, because a lot of these things are undermining those markets in such a way that are going to increase your costs. So have some time for some discussion or questions or thoughts. Leslie has a microphone there. And
Hi, thank you. Can you hear me okay? Hi, Dr. Damiano. Thank you very much for your discussion. Could you elaborate a little bit more on the Children's Health Insurance Plan reauthorization and what's happening right now in Congress, and what the potential impacts of cutting this particular program could be? I know
Sure.
It works different from state to state because
Right.
of funding streams and things, but I think it's a very important issue to this,
Right.
to the topic in general.
Yeah, no, great question. So the Children's Health Insurance Program, the CHIP program, as going back to your civics, you know that programs have to be authorized and appropriated. They have to go through both types of committees. The authorization for the Children's Health Insurance Program ran out at the end of, I believe it was at the end of September, October 1st or October 10th, something like that. And so the program didn't die because the appropriated money in most states is still carrying on for up to 6 months. And so you have 3 or 4 states that by December 1st, though, their money will be gone. I think Iowa, they're saying, is roughly March. So that's all the children who are between 0 and really 100, 133 and 400% of poverty who get public health insurance through the CHIP program. They would lose their coverage. The House has since passed their version of a CHIP bill, but it has what I would call a poison pill in it, and that to pay for it, they took all this money out of the public health fund, public health trust fund. And so the Democrats aren't going to go along with that. The Senate has not picked up, to my knowledge. There's probably behind the scene discussions going on about that, but to my knowledge, they have not come forward with a plan of their own in the Senate. But at some point in the very near future, the program would literally end, and all of the children in those states would lose coverage on a state-by-state basis until they sort of ran out, depending on when that dollar amount is. And so it really is a very important issue right now that isn't getting probably the level of attention that it should. So.
Thank you for your presentation. I'm not sure I should have come because it's really depressing. I should tell an anecdote, which is what really worries me. A friend's dad had a stroke, and he had good days and bad days. So after the initial MRI that made the diagnosis, he would get another MRI when he had a bad day. And then when he had a good day, they stopped worrying. But then he had a third bad day, they did an MRI. So he was waxing and waning. And he got better. But then when he had a fourth downward trend, they didn't do any MRIs because his health care insurance had been used up. What I don't feel from your talk is any control of the overutilization of services, which significantly drive up costs.
Right.
Are they trying to do that through these ACOs?
Right. So the idea in terms of how do you influence cost and utilization, the mechanism that's in the ACA is really through the establishments of these ACOs. And so if you think about the two basic payment options for healthcare in the United States, we've traditionally been under a fee-for-service system, which means the more somebody does as a provider, the more you get. And so the basic incentive is to overtreat from a financial perspective. In a capitated system where you would get so much per person per month, the basic incentive is to undertreat because you're going to get that money regardless of what you do. So what they're trying to do with the value-based purchasing is blend those things together, a little bit of the capitated payment saying you're going to get so much for these attributed lives, but then you also have to meet these quality targets or else you're not going to be able to do that, and that's what they're struggling to do because it's very, very difficult to do, and these are leaky ACOs, so the person, most of the time, the person doesn't even know they're in them, and they can go to any healthcare provider that they want often, depending on their plan and all those kinds of things, but in many of those, and then the provider or the system that they're attributed to gets dinged for those costs. So, I mean, we haven't figured this out, but that is exactly what this is trying to do, and to try to look at that idea of population health, and to try to get the health systems to think about that mentally ill person that keeps ending up in the emergency room. How do we get to that person, or how do we deal with the diabetic, that has high costs and high utilization? How do we, deal with the prevention side of that better? But it's really hard to do.
Don't they just dump patients?
Well,
They're toxic. I don't care.
I mean, there's absolutely the idea of cherry picking. And the rates should be adjusted to some extent based on severity and other things, but are they adjusted enough and in the right way so that it's going to do that? No. So is cherry picking going to be a part of that equation? Can they do it? Are they doing it? Who's going to do it? There's a lot of those kinds of things that do weigh into that, yes.
I have two questions about the Iowa Medicaid programs. One is, in a few sentences or whatever, if you could explain what's happening with the privatization of Iowa Medicaid and the problems that it's caused. And second is, a few weeks ago, the Senate Democrats proposed a public option out of Iowa Medicaid. And if you could explain the policy mechanism there.
On the first, about 2 years ago, the state opted to move everybody into managed care, as we talked about. And they contracted with 3 different managed care companies, AmeriGroup, AmeriHealth, and United Healthcare, that they basically were moving all of the Medicaid enrollees into that with this capitated payment basis and, risk adjusted to some extent and all those kinds of things. So the idea was that they would be able to manage those patient populations better than the state was previously. That was the premise on which that was done. To address your question, Bill, about how do you hold on, the idea was the state, the folks that made that decision were saying, we can't do it very well, so we're going to turn it over to the private companies to do it better. The problem with that is that you were taking somewhere between $300 and $600 million out of a $4 billion program to pay for the higher administrative costs and the profit that were built into those managed care companies, and then starting from that point to try to do that. And so what the managed care companies started to do which makes sense, is there's what are called, and this is true in the individual insurance market too, you may have heard of narrow network plans. And the idea is that if you go to only a narrower set of providers, they can negotiate better deals. And that's what the managed care companies started doing. For your average Medicaid person, may not be that big a deal. If you are a special needs adult who has had the same case manager for the last 14 years, and now all of a sudden this managed care company got a better deal with this person that might be cheaper but disrupts the pattern of care for that person, that's where a lot of those issues were. So you were applying the same premise to people with disabilities, people with mental health issues, and the mental health system had been managed by a company called Magellan for a long time very effectively. And the chronic condition health home program and the integrated health home program that Medicaid had started for people with chronic mental health problems had also been working pretty effectively, our research has shown. But then they turned these things over to the private companies. Those things didn't seem to be working as effectively because there were startup issues. All of these companies were new to the state to some extent. United Healthcare had been here before, but not in the same role. And so they're then putting together provider networks and all these kinds of things, and then you end up with this situation that we're in up until that next negotiation period where the plan started saying, hey, you're not paying us enough. And that's what had been seen in other states, in Kansas and a few other states, is that once you came, there's sort of a low ball at the beginning, and now it's like, now you've got to pay us more because our costs are higher. And that's when Mira Health said, you're not paying us enough, we're going to walk. And now you may have just seen just today, United Healthcare, Unity Point said now we may only negotiate or have our network be with one of the two remaining plans. And so then that starts limiting the options even further for people in Medicaid in terms of access to care and getting them, especially again, these are really high cost, high risk, very vulnerable folks, many of these people. They're the highest cost, most vulnerable people. That's by definition, that's why they're there. And so that's where you start getting a lot of the people are very concerned about what's happening with that. In terms of the Democratic Senate plan, I'm not familiar with that specifically. The public option idea was something that was being discussed at the federal level when the ACA was first being discussed, and it was to try to create more competition. So the rate setting is not mandated as a part of the ACA. They negotiated at the state level with the insurance commissioner based on their costs and say, okay, we need to go up X percent because our costs are going up. There's nothing that says you can only charge this or that. So they were worried about states like in Iowa, we had a really weird situation where Wellmark before had 70 to 80% of the individual and small business market. People thought they were going to come in and just dominate and there'd be no competition and they could set the rates of whatever they wanted. So the public option was supposed to come in and say, hey, we're going to have a Medicaid buy-in or a Medicare buy-in option to compete in those states so that there would be some price competition. As it turned out, Wellmark didn't come in for the first 3 years, came in for 1 year, only had 2,500 people in through the exchange last year, and then dropped out again, saying that they couldn't afford it. But there were other states where that idea. So instead of the public option, they included co-ops in the ACA as a way of trying to have sort of a public nonprofit approach to competition, but they really didn't work very well. You're asking a lot of a startup co-op to be able to compete against large insurance companies, and that it's a lot more complicated than what happened to the Iowa's co-op, but that's kind of the basis. No, Dennis?
There's got to be a reason why countries like Canada and the UK can have national health insurance. And America, we're supposed to be smart as they are, and we can't make a system like that work. I think it's the fault of the lobbyists and the big groups like AMA, who, like you say, they want to overtreat.
No.
We've shown.
I'm not saying that. I'm not suggesting the AMA wants to overtreat. No.
We have it seems like our government systems, like you look at the VA system,
Right.
and it's really broke. And people are just so scared of a government managed system that we will not look at a national health insurance?
I mean, you all could guess as well as I can in terms of why we haven't moved in that direction, but for the most part, yeah, I mean, there's a lot of fear of the unknown in terms of what would happen, right? And I think that's the people who are going to be talking about single payer. I mean, there was just something that just came out the other day when they were asking, actually asking people about their own insurance. Most people like if they have employer-based insurance, they like that. You say, we're going to move everybody into a single payer, that's this unknown that you don't know what's going to be covered, you don't know how good it's going to be. And sure, and providers are the same way. They don't know what that's going to mean, and you don't, because it's going to have to go through the sausage factory, and then who knows what's going to come out at the other end, whether it's going to be better or worse. Just one thing, when we talk about Canada and Great Britain, their systems are actually very, very different. And so, yes, they both have a government-financed approach, but the healthcare delivery system side is very different. In Canada, it's mostly private providers and private hospitals and private physicians. In Great Britain, it's mostly government-owned facilities and government employees who are providing the care. And in Canada, their insurance is at the provincial level. In England, it's at the national level. And again, just try to break some of those things down, just like we're talking about with these other policies in terms of the relevance to here. But as I said, could we do it? Yeah, I mean, we'd know how, but we haven't had the political will, if you will. There's one back there, Margaret.
Hi, Pete. Hey,
Yeah.
great presentation. I have a question. Locally, we just had Mercy Hospital made the front page for a lot of reasons. And we hear rumors that smaller hospitals are starting to maybe go under or change their practice. Is that because of this, do you think? And is ultimately losing those small hospitals a good or a bad thing? I think about the employees that were lost at Mercy, and that's tough.
Right. I can't speak to exactly what was going on inside of Mercy. I did talk to some people who were in administration over there. Are there things that are a result of the Accountable Care Organization development? Absolutely, that are challenging everybody because they're trying to hold down their administrative costs. And if you're a smaller hospital or a smaller clinic or a smaller physician group, something like that, it is really hard right now to stay independent. And then who do you align with and in what way, and how does the payment come back to you, and how do you get credit for things? And all those things are really, really challenging. And Mercy has tried to hold out and stay independent for a long time. And they finally reached the point, I don't know if you remember, it looked like for sure they were going to go with Unity Point, the morning of the announcement. And then by 4 o'clock they changed, and they ended up going with that Mercy system. And you've had a change in leadership there and some other kinds of things. And they're just trying to struggle to figure out how to keep up with this changing world, which is everybody's trying to squeeze costs. And when you try to squeeze costs, you've got unintended consequences, or you've got intended consequences, right, of looking at your employment base. And that's where your costs are. And so is it a struggle? Absolutely. What should rural hospitals even be? Depending on the rural hospital. Again, I'm not a rural hospital expert by any means. Keith Mueller in our College of Public Health, he is, and he's done a lot of work in this area. And it's a real struggle. I mean, they're changing. They're not necessarily full-service hospital. What should they be in what area? A lot of that has to do with your market. How close are you to other, bigger communities? All those kinds of things. But it's tough. And it's not likely going to get any better. And then once you lose that, what does that do for the vitality of a community? Margaret?
Well, as a British citizen here, I grew up on the National Health, and my parents both went through it when they were elderly, and I go home, I had a child born on the National Health. My comparison 35 years ago, tell me if I'm boring you, but I know I never bore you, Pete. No. My mother-in-law came over 35 years ago and was absolutely horrified at the maternity hospital I was in. It was state-of-the-art. It was World War II something or other, but painted, and it was just wonderful. But it was old, but clean, wonderful, and she had a fit that her grandchild was being born in this hospital. I had state-of-the-art treatment and wonderful non-technical, like my American birth, which is nothing wrong if you have to, but there's the difference. They're very much low-key. The midwives do the delivery until there's something wrong. They even stitch you up, which so there's a lot with the costs. And here midwifery is looked down upon a little bit, and it's sort of like, ooh. But the midwives are trained very highly. So the cost, and what I'm thinking is, in a lot of the American hospitals, and I am so glad I live here and have this wonderful treatment, because I've just been diagnosed with something and I wouldn't be anywhere other than here. But the Americans, no disrespect, but they want 5-star treatment in a hotel. Am I right in this?
Well,
You go
that's-
in and,
yeah.
and there's iPads, there's this, there's that, there's everything. And that costs money, and it's wonderful.
Right.
But
Well,
some children and some people don't even use that stuff at home.
Right.
And so, and then you take your own pajamas, you take your Kleenex. And so there's, and you're given it if you don't. So there's that kind of stuff that I see. There's also what Americans complain about, the waiting list. There are waiting lists, but by golly, if you've got a heart attack, you're in. If you've got varicose vein, then maybe wait. But the other side to this is, and I've played the two sides of the coin, because I lived overseas a lot, I would go home and go privately. So I got right in the door, and instead of going to the doctor and waiting, because I wasn't home for very long. So there's two sides of the coin, and you can get private health insurance. It's called Bupa, and some companies will let you pay into that, or you can do it privately. But having said that, I traveled the world because I was British. I never had to worry when I went home and I didn't have health insurance. When I came here, I wrote a paper about that. I felt very stuck in my job because if I left, I left.
Yeah, you bring up two
So,
really good points,
there you
Margaret.
go.
One is when you're thinking about international health comparisons, you also have to think about the cultural aspects, in terms of what would translate here and what would work. And yes, we tweak our knee, people want to go see the orthopedic surgeon right away, right? We don't want to see the nurse practitioner, we don't want to see the PA, we don't want to go through the primary care physician and then eventually get to the orthopedist. We have different expectations, and those things have costs. We also have a different proportion of specialists to primary care providers in the United States than most other countries. It's roughly 70% specialists here, 30% primary care. Most countries it's the reverse. And so you go to the specialist right away, they're going to be doing more intensive kinds of things, more procedures and higher cost. But that's what we know and that's what we've grown to. And so that's a very challenging aspect when you're trying to think about what works across that. So
I didn't go to the maternity until I was 8 months pregnant. Then the primary doctor switched me over. I didn't have a pediatrician. We had the midwife that came to the house, and then you go to a clinic for 6 weeks or something like that. So you only go to the pediatrician if you've got some awful disease.
Right, and again, that's not right. That's not the expectation of most people here. So, yes.
Hi. Hi, thanks for the talk. Do you think part of the cost that comes from healthcare also comes from the cost of education? Many doctors are going through their undergraduate, they accumulate so much debt there, then if they have a master's degree in between, or if they're doing things in between, maybe they're able to pay some of it off, but then they're incurring more debt, and then med school is more debt. And then, do you think that, do you think the cost of healthcare is more than just the medicine and how we're treating our bodies, but is also the external factors?
Well, sure. I mean,
How much
you
of
have,
that
yeah,
is-
I mean, no, that's a good point. You have to take all of those things into account when you're trying to figure out why our healthcare costs are so high. Again, that's what's 1/6 of their economy. All of us who are healthcare providers, all of us that are, that's all a part of the cost. And so there's sort of good things and bad things about that. There are people that say, well, we 17% of our GDP, it may go up to 21%. And some other people say, who cares? Because that's people's jobs, that's things. But the economists would say that's what's called opportunity cost. And as you're putting more into healthcare, it's less than we can put into defense or into environment or, into other things that we want to do. And it also hurts our international competitiveness from a business perspective, because the healthcare costs for our businesses are much higher. If you're making cars in the United States, the cost for the healthcare of your employees is going to be much higher than what they are in other countries. So that makes your products more expensive. So yeah, all of those things absolutely factor in.
There is one more thing, though.
Oh, sorry, Margaret, we got another person back here.
Hi. One thing I heard along the way, and correct me if I'm wrong, is that the only other country in the world that depends upon a patchwork of subsidies and individual mandates and health insurance companies is Switzerland. I was wondering if you came across that in your research and understood how it might compare to the U.S. trying to get further toward that system, given that we have population 40 times the size of that country?
Yeah, to be honest, I've heard of the Swiss system. I'm not that familiar with it. There's the Netherlands system is one I'm a little more familiar with, and that's an interesting one because they have 3 different levels of health insurance coverage. Everybody gets the same basically the catastrophic type of coverage. Then there's a tier 2 that everyone gets, but some of it get it through the public side and some of it get through the private side, their employer. And then there's a tier 3, which is an optional for things that are, beyond what they would consider the essential health benefits package. And that seems like it's something that could be adopted here if we wanted, so that everybody got that catastrophic coverage. Everybody got routine, but there's going to be some things that are beyond that. The Swiss system, I'm sorry, I'm just not that familiar with.
The British system
Yeah.
is free, by the way.
Right, well, none of them are free, right? I mean, everybody is paying for it either directly or indirectly through taxes and things like that. So, right, yes, sir.
Hi, you mentioned in the slides talking about health homes, you mentioned the integrated health homes, and I was just wondering how, in your research, you've noticed how well that's been implemented. I mean, there's a lot of ideas of having social workers or nurse practitioners or nurses doing health coaching and all those kinds of things that help in a lot of different ways. I won't go into it anymore, but I'm just wondering how much you've seen that being implemented.
Well, right, there's a model of care called the patient-centered medical home that grew out of special needs kids about 25, 30 years ago that had to go to a lot of different specialists and a lot of different types of healthcare providers, and to try to coordinate that care better, that benefited both the child and the family. And then that's been tried to be expanded into other types. In terms of with the ACOs, many ACOs are hiring more care coordinators, case managers, all these kinds of things. Is that enough in and of itself? No. I mean, is it a step in the right direction? Absolutely. And can we do a better job of integrating care for the people who are the highest cost, have multiple chronic health conditions? Absolutely. But how we do that cost effectively is, to me, still the real challenge. And is that a piece of that? Absolutely. Okay. All right, well, thank you all very much. I really appreciate you coming out and being a part of the evening, and good questions, everybody.